Okay, we're going to go ahead and get started. Good morning, everyone. My name is Erin Flynn, and I'm a Senior Policy Advisor at the Department of Vermont Health Access, and it's my honor and pleasure to welcome you all to the first day of the Vermont Healthcare Innovation Project's Core Competency Training for Frontline Care Coordinators. I really want to thank you all upfront for your commitment to this important training and to acknowledge your efforts to carve the time out of your demanding schedules to be here. I know it wasn't easy. I'd also like to personally thank you all for your patience as we work to accommodate all the requests to attend this training, ultimately resulting in the addition of a second Burlington section. It was really inspiring to us, the outpour that we got to attend this training. We're excited to be here today. But before we begin, I want to take a quick moment to acknowledge some members of the team that worked tirelessly to put this training series together. You may have seen Holly Stone out at the registration desk. Without her, this would not have been possible. Carol McGoffin, Pat Jones, Julie Wasserman, Deborah Lacey Baker, and our project director, Georgia Maharis, amongst others. Without everyone's work, this training would not have been possible today. As each day passes, I become exceedingly amazed at the hard work, dedication, and passion that you all devote to improving the lives of Vermonters, especially those with complex needs. I've seen providers across communities statewide come together and reimagine the way that they work together in partnership with individuals to ensure that their goals and needs are being met. As a result of your tireless commitment to this work, I've heard care coordinators referred to as magicians, and have been told by the parent of a young girl with complex need that care coordination truly saved her family's life. And she looked me in the eye and said, "I don't say that lightly." I've heard story after story about how through collaboration, engagement, and teamwork, you've reached some of the hardest to reach Vermonters and made things happen that were previously thought impossible. As you continue your relentless efforts to coordinate care for Vermonters with complex needs, we hope that this core competency training series will offer you additional tools to support you in this work. Before I introduce you to our trainers, I want to make a couple of quick notes about logistics. I think you've all received an agenda in your packets that you got at the registration table, so you'll see that we have a lot to cover today, but we do have a couple breaks scheduled for both the morning and the afternoon. There is a bathroom located outside the door around the corner to the right. I think that there's another one that, in case in breakout times that gets a really long line, we'll let you know where the other one is. We're going to work to find that.
Just on the second floor downstairs.
Okay, so we'll make sure you know how to get to that one too. When I wrote these welcoming remarks, I had made a note that there's a beautiful, lovely terrace outside off the lobby with a nice garden and some tables where you could take a moment to relax, but maybe not so much today. But we will be back at this training site for future training, so hopefully we'll get an opportunity to take advantage of that in the future. So we allotted an hour and 15 minutes for lunch. Given that we weren't able to provide lunch for all of you, we want to make sure you have time to go grab some lunch and be back here. The advantage of being right here on the waterfront in downtown Burlington is that there are plenty of options right at your fingertips. If you need any recommendations or directions, feel free to check in at the registration desk and we can help you. So without further ado, it's my distinct pleasure to introduce you to our trainers from the Primary Care Development Corporation, fresh off the plane from New York City. Founded in 1993, the Primary Care Development Corporation is a nationally recognized nonprofit organization dedicated to expanding access to quality primary care, to improve the health of families and communities, lessen disparities, and reduce healthcare costs. To date, PCDC has assisted more than 900 primary care practices at over 400 organizations across the U.S. to deliver a patient-centered model of primary care. PCDC has extensive experience in managing, implementing, and evaluating quality improvement initiatives, including chronic disease management, workforce development, patient-centered medical home transformation, health homes, and integrated care models. PCDC has developed and delivered nationally recognized trainings, such as the Care Coordination's Fundamental Course created in partnership with 1199 SEIU Training and Employment Funds, and the Team-Based Care and the Patient-Centered Medical Home course. PCDC is also currently funded by the U.S. Centers for Disease Control and Prevention to provide free training and technical assistance to health care organizations across the United States to increase their capacity to deliver comprehensive HIV services along the HIV continuum of care. Their combined experience represents decades of on-the-ground work training a wide spectrum of healthcare providers, and we're thrilled to welcome them to Vermont and look forward to our many days of training ahead. So with that, I'll pass it off to Carla Silverman, who is going to introduce you to the rest of the PCDC team. Thank you very much.
Great, thank you. Great, thank you. I'm gonna try this, or we're gonna try this without a mic, and maybe you can give us some feedback if that's not working, but I think our style is really gonna be very interactive. We're not gonna lecture you too much, so we're gonna be moving around, so if we can do it without mics, and how can people in the back hear me? Seems okay? Okay, and if you can't at any point, please let us know. So we're thrilled to be here. We're really excited. This is the kickoff for really a year of trainings, and we're honored to be working with you and excited to share what we know and learn from you as well. We have really deep, great respect for what you do. I want to just introduce myself and my team. Where's the rest of my team? Where's Kimmy? She went. Oh, okay. So I'm Carla Silverman. I am the interim chief program officer at Primary Care Development Corporation. I'm also a senior trainer there. I'm the lead author of the Care Coordination Fundamentals course, which maybe some of you have seen, maybe not. It's something available on our website, and in your packet that you have a link to it. You can download it for free if it's something you'd like to look at. Probably very relevant for the work that you do. My background is as a registered nurse, and I'm a certified nurse midwife. I provided prenatal care and primary care and family planning services for close to 10 years in the South Bronx and Washington Heights in New York City. I was the clinical director at Planned Parenthood in Westchester. I've been at PCDC for close to 5 years, and care coordination and care management has kind of become my special interest. So done a lot of operations work, helping people set up their care management program and their care coordination program, plus trained many care coordinators and care managers. On the rest of my team, maybe I'll let them introduce themselves. Go ahead, Maya.
Hi everyone, my name is Maya Baroud. I've worked at PCDC for about 4 years now and actually assisted Carla on the original care coordination course as well as team-based care, bits and pieces of which you'll sort of experience through this training. My background is in community health care. I worked at a community health center for several years in Connecticut, and today I do a lot of work. I do some work with care coordination. I also spend a lot of time coaching practices around patient-centered medical home.
Hi everyone, I'm Yael Lipton. I've actually only been at PCDC for about 6 weeks. So I work part-time as someone who develops all the training curriculum and also as a trainer. I'm a health educator by training and profession, and I've spent all of my career working in underserved communities, primarily in New York City, on both prevention and treatment and education programs around sexual and reproductive health, diabetes, general health and nutrition, breast health, lots of other things. Throughout all of that time, I've also created and done a ton of training for both healthcare providers as well as social service providers on things like improved patient-provider communication, shared decision-making, a lot of stuff on health literacy, which you'll see some of it today, how to talk about tough topics with people that you serve. So this is my favorite thing to do, and I'm really happy to be with you all today.
Great, so I'd love to just for a moment get a kind of sense of who's in the room. I wish we could do intros, but we'd be here probably all morning doing that. Can I see a show of hands for anyone who's a nurse here in the room? Okay, social workers? Great. People who work in housing? All right, got the housing crew here. Well, what other kinds of people do I have in the room? Community health workers, what are you?
Actually, SASH coordinators.
SASH coordinator, is that housing, SASH?
Well, we don't, some kind of housing and also social workers.
Housing, social workers, right. Anyone else? Any other types of licenses in the room? Any doctors or NPs in the room? What are you?
We're two people from Vermont Family Network. We're a family organization and nonprofit.
And what kinds of services
We
do you?
help families with children with special needs and disabilities.
Children with special needs. Okay, great. Good. Okay, wonderful. So we're gonna get started here.
Just one note, I think if you didn't get a packet, Kimmy, our other awesome team member, is standing in the back. If you want to just raise your hand, she'll give you one. Sorry, Carla.
No problem. All right. This is a little challenging. Let's see. All right. So, some words about the day. I guess I could stand here, right? Then I could see that. So like I said, I don't think we're going to use microphones, if you guys are cool with that, because we're going to move and not be too static. Just to let you know, we're going to do a lot of activities. We're going to sometimes do them in larger groups, like this whole room, and other times we're going to do breakout groups. And you'll see there are signs. That's breakout group 1. I think that's breakout group 2 back there. And over there is 3. And in a little bit, we'll ask you to actually move to kind of clump in these areas, and we're going to try to do maybe groups of 20. Okay, so we're going to have you up and moving and interacting, and we really believe that people learn by interacting more than us just like passing information to you. And in fact, you guys know a lot of things that we don't. So we really want to encourage lots of conversation and sharing with one another. If you have phones, if you can just put them on vibrate and take any calls out in the hallway, that would be really appreciated. You have a packet, you should have a resource packet. In there you will see sometimes handouts that you need for the day to do activities. Some are other things that you might want to look at when you get home. As I mentioned, there is a page that has links to articles and resources that we think are really helpful that you may want to pull up, for later. One thing I didn't ask, how many people in this room are trainers or are going to go through the whole series and be trainers later? Anyone? Great. Okay, good. So we'll be seeing you later in the fall, and you might want to pay particular attention to those the links that have those resources. Just a couple other things I wanted to mention. When we were talking to the state of Vermont, someone pointed out that we were using the term patient a lot. I myself am a nurse practitioner, as I mentioned, and so we do sometimes say patient. I know social workers often say client. I know other people say individual, and I just wanted to kind of put it right out there that we may use any and all of those terms. And we mean whoever you are caring for or serving, and just wanted to hopefully not offend anybody, but just be clear that we're using those things interchangeably, and we're aware that it's you might say client and we might say individual and they might say patient. The last thing I wanted to mention is that, and we'll get more into this, you will hear us use care coordination and care management, I think, fairly interchangeably. We don't really believe, actually, that those words are totally interchangeable. My feeling is care coordination is for all patients and care management is probably for more high-risk complex patients, but we could talk more about that later. And I'm curious, anyone who do you guys call yourselves care coordinators or care managers? Who's a care coordinator? Okay, and who's a care manager? Okay, so mostly care coordinators, but again, you'll hear us use those terms interchangeably, and we basically mean the same thing. So just to go over our objectives for the day, we're going to talk about how care management can address barriers and social determinants of health, and we'll talk more specifically later about what those are. We're going to talk about what is working well and what's not working so well in terms of functioning as a team. We're going to talk about strategies to engage healthcare providers in care management and care coordination work. We're going to talk and think about how our culture's view of chronic disease can affect people living with those conditions, and also potentially how we care for people with those conditions, and talk about some strategies to overcome that. We're going to talk a lot about health literacy and do some exercises and activities to figure out how to address health literacy issues with our patients. And those are going to include using plain language in your work and using the teach back method. And remember, today is day 1 of a 3-part series, right? So I'm assuming I'm going to see all of you again in May and in July, right? So, because it's a 3-day course. And a lot of what we learned from you today, we will take back and incorporate into what we're planning for our May program and our July program.
Carla, sorry, just a word. 3 days with one training organization and 3 days with another training organization. I heard some whispers saying, isn't it 6? It is 6 days.
Oh, sorry. I'm so sorry. Yes, there is another organization that is providing disabilities-focused training that I think runs in parallel with us. So I think you see us, and then you see them, and right, you have it monthly, I guess, right? So we'll see you again in May, but you'll see them in April and June and August. Great. Okay. So I'm going to give it over to Yael.
Okay, so we want to jump right into something fun and get us thinking about our role in healthcare and thinking about the healthcare system. So what you're going to do is I'll explain the directions first, but I'm going to need everyone to get up. I'm going to ask you to find someone that you don't know. I assume that's possible for everyone here. If you happen to know everyone, find someone you don't know as well. Introduce yourself, and then you're each going to tell each other about the best healthcare experience you've had that you can remember. You do not need to disclose any personal information about, what condition, you were being treated for, anything like that. But I want you to think about these questions that are up here. So what made the experience so memorable? What did the people involved do to make it so memorable and positive? And then specifically, who was involved? Okay, and I'll give you a few minutes to do that. So, this is just the first of lots of getting up. So, so take a stretch and go ahead. Okay, I'm going to ask everyone to pause for 1 second. I was overhearing some great stuff. So what I want you to do now is find another person, let's see here, that you don't know again, and you're going to do the same thing except for an unpleasant, your worst, doesn't have to be your worst, but something, an interaction that wasn't as good as your best. To answer the same types of questions. Okay, if you could just wrap up and then you can take your seats, we'll move on. Okay, great. So just by a show of hands, who found it easier to think of the positive experience? Okay, so everyone look around. Can you keep your hands up just one more second? Okay, and how many of you, I'm assuming, everyone else, it was easier to think of the negative? Just put our hands up so we can kind of visually see that. Okay, so it looks like it's about half and half. All right, so how have these experiences that you've had shaped your view of healthcare? Whether it's in your state or in the U.S.
Do you want us to answer that?
Yes.
Yes,
Okay. When I was, I'll focus on the negative and then I'll focus on the positive. When I was talking with the person that I grabbed, I had said, as far as the negative, that I think we have really great healthcare workers here in Vermont. I think the biggest issue is the amount of time that they can spend with their patients, because they have, within the practice, they're kind of under time constraints because of reimbursement structures. And so sometimes patients don't have enough time to really address some of the issues that are really plaguing them.
Okay, so I don't know if everyone heard that, but it was about the fact that you have good health care in Vermont, just limited in the amount of time that providers can spend with patients, which I think is kind of a universal thing, right? What else? Go ahead.
Just generally lowered my expectations because I had the same experiences. You go in the same waiting room, same old magazine, don't be looking, just after time it's like, whatever, it is what it is, managed care.
Interesting. Yeah, that's really interesting. Anyone else? you and then.
I just, it was interesting because I didn't raise my hand for either, because I had, both good and bad experiences. And, I think what was really helpful about doing this exercise is, I was very aware of what was present in my good experience was not present in my not so great experience. So the good experience, I felt heard, I felt part of the team. Bad experience, I felt like they were just dictating to me, they weren't hearing me, they were telling me what to do. So, that's what
That's
my
great.
experience has
That's
been.
great. Anyone else want to expand on that? I know you had something to say.
Yeah, well, I'm a nurse myself, so for me it was easier to sort of focus on the negative because I expect that my peers, that we do give good health care.
Okay.
So I'm always just kind of amazed and surprised when people say that their experiences have been negative because I'm expecting that it's gonna be positive because I work with great people.
Okay.
And I know that, and I don't originally come from here, so I moved here and it's like they're even better here than they were where I was. So it's kind of disappointing, I think, when I hear about the negative because I just know that it doesn't have to be that way.
Interesting.
Can I just piggyback
Yeah.
on something here? So just to, keep in our minds, right, you're a nurse and you give great care, I'm sure, and the people you work with do, right? But we were talking about this in our car ride over here. Sometimes the system that we work in is no one's really thought that out, right? So even though individually you're doing a great job, you work in a system that perhaps is uncoordinated or no one has actually kind of stood in the shoes of the patient and walked through what their process is, and that's often where the problems happen, right? That's why all this focus now on coordinated care. So keep that thought in mind today as we go through our work.
That's great. What about the people that you work with, whether you refer to them as patients, clients, people? How do you think their experiences have been? Do you think they're similar to your own, different, and then kind of why? Any ideas or thoughts?
Yes, I have a couple. I'm not afraid to speak up, and I don't view my healthcare provider as someone who has, I know that they have a lot more training in the field than I do, and I respect that, but I'm not intimidated by them, and I feel like sometimes the population that I work with are afraid to speak up, and they just, in not being able to do that, sometimes they don't have real good communication with their health care worker, and then things get missed.
Okay, so that's great. Some of that, what you just said, has to do with health literacy, which we're gonna get to towards the end in the back. I see you.
I feel like if you don't ask, if the clients don't ask the questions, that the doctor isn't going to talk about anything with them. That might be a worry or a concern, a side effect.
Okay. Yep.
Kind of tying it together, a negative experience with having a doctor that kind of clicked his fingers to get the nurse to hurry up and kind of was very, very intelligent and really knew what he was doing, and I switched primaries right away because I really didn't like that. And I think sometimes with the patients, they talk about it to me, the SASH coordinator, where they are not talking to their doctor, so they may stay with that doctor longer and start missing appointments and not go. So I think that might be a little bit of a difference, but.
So let me just ask this before I move on. Whose responsibility is it? You were talking about there's miscommunication. Patients are intimidated or they don't ask the questions. So therefore the doctor or the provider won't talk to them. Whose responsibility? Yes.
Well, I think the point that you made is really important because I see it all the time. It's the system. The system doesn't respect each other. And when you don't respect your system, because there's some flaws in it, and it might not be intentional, there'll be a lack of communication because people aren't sure where they stand. So that affects the patients, the clients, the snowball effect of it. And the thing is, nurses and everybody within doctors' offices, in my opinion, in hospitals, are so overworked and so exhausted. The hierarchy needs to respect that system more, and then they'll respect themselves more, which they do, and it's a snowball effect, and there'll be amazing communication. Because I've been in hospitals from Vermont all the way down to Boston, all the way to Seattle, Washington. And when you're in a good system, you know it, and you can feel it even with the vibes of when people walk in your room. So it's the system.
Okay. Did you want to?
Yes, I mean, I think I don't think it's the responsibility of the patient because, like someone said, I mean, they feel intimidated and they oftentimes don't know what to ask. And they don't even know that it's a question because they don't know anything about it to even know that there's a question. So I think it's the responsibility of for me, it's my responsibility as the nurse when I'm talking to them to make sure that, did you get your questions answered? Were you able to get your prescriptions filled? Are you having any side effects with your medicine? Did you know you can't drink if you take flash? I mean, just all these like little things that the doctors just aren't gonna have time. It's not because they don't want to or because they feel like it's not important, it's just that they don't have time. And those are the things that are gonna cause the patient to have problems afterwards, I think.
Okay.
You
We're
want-
gonna,
you want one more
oh,
person
one
back
more
there?
and then we're gonna move on. Sorry. I
Did you
missed
want to speak?
Go ahead.
I have to agree with her too. I think it's the provider or the nurse, whoever's giving the care, because you're setting the example and you're giving the care, you're getting a rapport with the client to make sure they feel safe with you, that they're gonna open up and tell you what's on their mind and what they need help with.
Can I jump in for 1
Yep,
second?
and then we're moving
So
on.
these are great responses. I would also say, right, you're all care coordinators or care managers, even though you have your, perhaps, you know, your licensed roles, your nurse, your social work. Like if we think about why did care management and care coordination come around, it's because there was this piece missing, right? Even nurses who are trained to do this kind of work don't have time necessarily in their role to be linking patients to resources, to be doing coaching with them, to be engaging them, to be helping them advocate and ask questions to their doctor, right? So this again is part of the role that you all play, and many types of staff can play it, right? Even in New York, we have a ton of unlicensed people doing this. They get training to do this. Often they live in the same communities as patients. They speak the same language as their patients. They are linking, you know, those patients to providers and helping them get what they need.
Great, let's move on.
Yeah. Oh, so is it me?
Yep.
Great. Okay, so we're gonna move on to another exercise. We're gonna talk a little bit more specifically about what kinds of things can affect people's health. So I'll just put that out to you now, and I think Maya's gonna scribe. What kinds of things can affect people's health? Yes.
Financial stress.
Did you say financial distress?
And nutrition.
Yes. Okay, so their financial situation, nutrition, education level, their housing, absolutely. Transportation.
Drug and alcohol abuse.
Addiction, drug and alcohol abuse. What else?
Family dynamics.
Family dynamics.
Mental health.
Mental health. How you going, Maya? You guys are fast. What else?
Dietary habits.
Sorry, what was it?
Dietary habits.
Dietary, I think that was in nutrition, yeah? Right, what you eat. Your race, yes?
Motivation.
Motivation.
And
Me-
it
what-
may be because of all of the other things, that they're not motivated necessarily to be healthy because they're so worried about all the other things.
Right.
But their motivations.
Right, or I would say maybe engagement, yeah? Are they engaged or,
Are they motivated?
okay,
To go and seek help?
yes, okay, motivation, yes.
Unknown health conditions, if they aren't aware a health condition exists, that may affect their health until they find out.
Right, so you mean they're sick but they don't know that they're sick, or?
Somebody could have had a stroke or a brain tumor or, something that's affecting their health and they have no idea.
Right.
Because they have not been to find out.
They haven't diagnosed, right, so undiagnosed conditions, maybe. Yes?
Fear.
Fear, absolutely, fear.
Have you ever considered rewording that question to what doesn't affect someone's
Yeah, I guess I could, but no. We have a plan. With these words.
Okay.
Medication, like if someone's given pain medication and they get constipated and they're not told, you know.
Yes, medication, right.
Medication is can
Right.
mess them up.
Side effects, if they take it, if they don't take it, all sorts of things around medication, yes.
Healthcare access, quality of healthcare.
Absolutely, access and quality of care, yes.
The insurance.
That ties into.
One sec, hold on, got it in the back. If you live in poverty, right, goes under financial, most definitely. In the back.
People's own choices.
People's choices, yes.
Transportation.
I think we got transportation.
Yeah, we have
Peer group is on there.
Peer group, okay. Culture, would you put that in the same, yeah?
Environmental, outside of social, example, Flint.
Yes.
Michigan, sense of helplessness.
The environment.
It's an extreme case, but it
Yes,
certainly is.
the environment you live in, the neighborhood you live in, right, things that are outside of your control. Yes,
Primary language.
the language, your primary language, right? If it's not English, that's another hurdle to come over, right?
pretty good list.
These are good. Anything else? There's some, there's a couple I have in my head that I don't see here.
Culture, you mentioned that should really be on there.
Culture,
All I can think of is like a lack of communication. I work with a lot of deaf people, and I have a hard time trying to understand what they need.
okay, right,
So sometimes they lack.
right. Communication,
Race or ethnicity.
right, we said we have race up here.
Family history.
Family history. What else? There's one biggie here that we're missing. In the back?
Religion, which subset of culture.
Okay, religion, we could put that.
Lack of childcare if they can't get there because they have. no
Okay, that's a good
children.
one. Lack of childcare. In the back? Yep, you?
Gender
Oh, thank you. That's the one I wanted. Gender. Right, gender identity and difference of care depending on what your gender is.
Confidence in themselves to advocate.
Right.
Sort of your motivation.
If they're in a wheelchair, they might not be able to walk into the doctor's office, there might not be an access ramp.
Right. Okay. What do you think? We're good?
We're good.
Okay, so here is what we're going to do now. Now we're going to do our breakout groups. So what we would like is, I would say all these people here are in this breakout group over here. And maybe a couple people, like you guys, also come over here or sit over here. And then we have a breakout group in the back. I'm sorry about my cough. And then the last group is over on this side. And what we're going to do is have some smaller group discussions about specifically how these things actually can affect people's health. And then we're going to brainstorm some interventions that I'm sure you guys, use every day with your patients to overcome some of these barriers and issues. Okay? So breakout group 1 or 2 is over here. The other one is back here. The other one is here. I'm going to get a cough drop.
We have created a list of most of the things that came up and a couple things that didn't. What we want to talk about as a group is just very quickly, how do these things affect someone's health, and then really about how care management or care coordination addresses this. It might not be able to address all of these things. I have 2 pages of them, and that's fine, but we just want to have a discussion around it. So for economics, just quickly, can somebody give an example of how someone's economic situation may affect their health?
A homeless person that was living in her car. She was abused and lived in her car for 3 months. So she had no housing. She had little to no food. If she could couch surf, she could. So getting her health care or
That probably wasn't the first thing on her mind.
her first thing was and also transportation. Even though she had Medicaid, it was a barrier because she lived with her dog.
Yep.
And so she had a car, so she couldn't. So it wasn't even a transportation, and it's wintertime in Vermont, so she was always conscious of how long the dog was staying out in the car versus, and then running out of gas money.
Sure. Okay.
Just lots of stuff.
So I think this one, in terms of how it affects our health, we get it, right? Like, we're in the U.S., money affects everything, right? Having a lot of it or not having enough of it. So how does care management or care coordination address this, and if so, how?
So how is this perhaps an issue?
Like, as a nurse, Okay, sorry, I'm gonna try to
Access to public benefits.
Okay.
Someone was told they were had hypertension, they didn't really understand what it was.
So you're saying, so, yeah, and we have this, I mean, I've done most of my work in New York.
And work around eligibility, helping people apply.
People who are eligible for things, but they just don't know it, right, or know how to go about doing it, perfect. Yeah.
I think it also just provides the opportunity to actually even acknowledge that there are financial stressors going on, that role just serves as the opportunity to take that extra time to explore what are those issues.
In this situation, there's a lot of programs, but they all have their own little niche, and sometimes the person does not fit the eligibility for a particular program. So, you know, I found that even though there were lots of resources, and even though people wanted to help, it's that system thing where she was under 60, okay, where she had you know, I mean, there was a lot of restrictions. So I think the programs are there, but they're so diverse. Everybody has a little bit of money, and so we're all trying to tap into that, but they have their restrictions.
Yeah. Right. There was one checkbox that she didn't meet, so therefore.
Right.
Yeah. That's infuriating to me. Anyway.
Well, there's
Anything else on this?
There's two things that can happen here. If the person who is working with a person who is in this situation and they don't know specifically who would be the best agency to work with them, they can always contact 211 as a starting point.
Okay.
And 211 then can, or they can contact, if the person that they're working with is over 60, they can always make a referral to the senior helpline at our local agency on aging. And then a comprehensive assessment can be done to determine what they need to help them work.
211, I assume, is like Vermont's 311. Is that where did they get the idea from New York City's?
It's national.
National.
Oh, national.
It's a national.
Except for a couple of states.
Okay.
Yeah.
All right. Anything else on this before we move on?
I think pride.
Sorry.
There's almost a deliberate obfuscation.
One thing, sort of as a care coordinator, because there's so many different programs with different that have different sort of focuses and eligibilities. As a care coordinator, you can sort of pull everybody together and coordinate for a patient, instead of them having to sort of sift through it all themselves.
Yep.
Access is what she's saying, or you're much less.
To make a plan that makes sense, right?
Right.
Great. So I'm sure there's others. We're going to move on just for the sake of time. Health literacy. That didn't come up, but we're going to do quite a bit on health literacy. I don't want to get too into definitions and making sure we're on the same page, but how does someone's health literacy affect their health?
For a lot of these programs, there's applications, and they don't necessarily know how to fill them out or fill them out correctly. It's not real clear even to me what exactly they're asking.
Yep, forms.
Okay, right. So again,
Forms are intimidating to people. Yeah.
Sometimes it's the ability to understand what the doctor has, the language the doctor has used, or the language that's in the paperwork that's given to them.
Yep.
police or, of course, we would never do, but there are places in this country where that could happen, you know?
Okay, anything else?
Interpreters, right?
I don't think that especially our elderly population, think about health maintenance. It's all, you don't go to the doctor till you're sick, and they don't know that if things are checked, that they aren't going to, get problems. They wait until the problem is so far gone, especially our diabetics.
Okay. So how does care coordination, how may it address this? Or does it?
You can educate
Better term, undocumented, but yeah.
in all of those areas, assist with application, help understanding the language and
So maybe better
communicate with that.
education through care coordination, yep.
And really helping the professionals understand where their family's coming from.
Sorry?
Helping professionals understand where their family's coming from and what their understanding is.
And again, state to state,
So
right?
helping the professionals sort of
Like we did a whole lot of
get
work
down
with
to
Indiana.
be able to talk in a way a
Might be very
family can
different in Louisiana if you're undocumented than it might be in Vermont. What you have access to.
Almost that one-on-one.
I think it also, care coordinate, at least with our case managers at the CVAA, it's giving voice to the client providing that opportunity, through motivational interviewing or just time to actually voice whatever is going on, that they can then connect to the healthcare world.
Okay.
Yeah.
I don't want to forget this side. I have my back to you for a few minutes. I'm sorry.
Access to education about chronic illness and some of their own illnesses and ways to support that. So, I mean, I have a lot of clients who come up by building, and it's like everyone avoids them.
Sort of along the same line as the inability to understand. We work with a lot of new Americans, so having information that is in the language that they speak, so they're more able to understand it.
Yep.
And along that line, just remembering where they came from. I have patients who refuse to see it, or patients who refuse to see a doctor from India.
Immigrant.
Literally and figuratively.
So that was a great experience.
Access.
Sorry, and country.
Even
This thing is not that easy to write up.
If you
He's got no back, so I'm like, so by down here, we're not gonna be able to read anything. Okay, so let's move on. This is great. Insurance status. So just quickly, this one's also sort of like, I think we get this one, right? If you don't have health insurance, it's hard to get good care. Okay, so how does care coordination address this?
Day in and day out.
Even with people that have insurance, a lot of times they don't know what their benefits are. So insurance status, I would say understanding their benefits or how to access their benefits, because a lot of the insurance companies say, we'll go to the internet, look on our website, and it gives out paperwork anymore, and they don't understand.
It's hard for the most educated of us.
Some people have never had a PCP before. They just are like, I'm sick, I go to the ER.
Right.
So they don't, it's not just, sometimes people, especially with the expanded Medicaid and everything, they get insurance for the first time, but they don't understand really how to use it, so I do a lot of education, around insurance.
Yep, very good, that's great.
There's a SHIP state health insurance program for Medicare recipients, housed in the area agencies on Main Street. There's a lot of training and information classes.
Okay, so referring people to that, that's great.
And insurance status, there's a lot of cost. There is cost, whether it be a premium or a copay or an out-of-pocket expense, which goes back to the economic financial, but it even hits the middle.
Sure. Anything else in this one? Well. Do you think this is safe? Think anyone's gonna yell at me here? I'll be gone, so it doesn't matter. Try to find me. Okay. Sexual orientation, which didn't come up, but we had it on our list. How does that affect someone's health?
There's a lot of conservatives in the Northeast Kingdom, so even though we're a state that thinks that they're very liberal, they're not. So there still is that.
Okay. So how would that affect someone's health? I'm with you.
The doctors might treat you differently because they don't understand sort of the situation or their personal views get in the way of it, which is an effort.
Or the patient even afraid to ask.
Yeah.
Right.
So I would say it wasn't just the doctor, but more the staff. It's the first time that they go from the first person they meet, the whole staff.
The
professionals.
So both the treatment might be, compromised, and also people may fear. That's what someone said, right? Going to, right.
They'll just procrastinate because they.
Right, because of discrimination.
Or they won't feel open to ask questions or.
Okay, so that's good. So how does care coordination address this? And if so, how?
Nothing. They have an inherent.
Talking to the doctor's office to try and educate them necessarily about the person's situation, kind of advocating for them.
Kind of figure out what
educate practices. Okay.
Well, I think there's a validation in the process of looking at the individual.
I go back to motivational interviewing again and empowering the client to kind of give voice to where they're at. And, I've seen our case managers, not necessarily with this situation, but rehearse, what are you going to ask the doctor? Do you have a list, sort of prep for whatever is coming down to feel more prepared?
And even having open.
Safety and respect. Okay.
Yeah.
Okay. I like that. Validate.
Great.
Go ahead, you can
So let's do
talk
this
while I'm
one.
writing.
Sorry, I'm gonna keep you
I was just gonna jump on, even having that open conversation with the care coordinator then may.
Yeah.
I've been able to reduce some fear.
Right.
I would put manipulation or
Right, exactly.
having enough staff training as well, so that we're aware, we have the awareness that we need to, talk to folks. And even assessment tools and things that have even practices in agencies are we addressing those needs and those questions and giving people the space to even communicate about it.
How do we address this?
Possibly driving, I don't know that much about Vermont, so I apologize, but maybe driving people to a health center that, specializes, right? That's what I was thinking. Okay, let's go on to culture. So how does culture affect someone's health, briefly?
What else?
Every way, but I know that. But let's be concrete. I get it. We all get it, but let's verbalize a few things.
What someone might feel comfortable talking about with a doctor would be very
Okay.
different.
So comfort or discomfort in what you would,
What you talk about
tell.
and what you don't.
Right.
Language barrier.
Clearly language barriers, yep.
A lot of the New American culture don't even have the same language in the same understanding or the same belief system around healthcare or different kinds of disabilities or health conditions.
Okay, so how does that affect someone's health?
Understanding.
I get it, I'm pushing for a little bit more specificity.
So they might not be on the same page in terms of interventions and
Other things outside of the language or culture.
I think that, sometimes I think about the Hmong. Did you ever? Yeah, and
Know
how
them well.
there was a case where this young woman had a seizure disorder, and her family felt it was a blessing from God that she was
catches
blessed.
you and you
Yes,
fall
and you
down.
fall down exactly. And her doctors saw it as something to be fixed. And so I think kind of taking into account.
That's a great book.
Yeah.
When I worked at a community health center and I had a team of 17 health educators who ran programs, whenever anyone would start, I'd make them read that book. It's a great book.
So just even being on the same page about what is illness
What
and
you call things,
what
right?
you call things.
Okay, so how does care coordination address this?
Language line.
Okay. Everyone knows what that is, right? Or does everyone know what that is?
Yep.
Patience and repetition.
Patience and
Having the patience to take the time.
Can you guys hear in the back? So she's talking about there may be these free clinics, but transportation is a really big issue, and people are.
You were discussing, Marinelle said, some of our New Americans don't understand the word autism, and they just want something to make it better.
Right.
So it just takes time,
Right.
patience,
Yeah.
repetition.
Yeah, I love that you said that, because that's like the opposite of what our healthcare system has, right? Patience or time. So that's great. And I would say, even I would add to that and say building relationships, right?
Right.
That's what it ultimately does.
Right.
And then that's where you can really, once that happens, you're good.
Right.
Maybe understanding how their culture impacts their healthcare decisions, end of life and care.
We ourselves can educate ourselves.
Who makes those decisions?
Where are these places and how can people get to them? Okay, this last one, what can we do as care coordinators?
I think that case manager can be a bridge between healthcare and culture and the individual.
Yeah. Right, often, the doctor's ready to do these 10 things. The patient hasn't even accepted, right, that they have this diagnosis. And so you all can be the bridge to say, I hear you want them to take 20 medications now, but they're not ready and here's why. Is that what you're saying? Perfect. Anything else? I'm just checking.
Not being judgmental.
Okay.
Because sometimes their homeopathic or their health practices may not be the same as ours, vice versa.
Right.
So
how do you provide non-judgmental care and also show that you're not shocked, right? Some of the things that we hear, every now and then we are, right? Okay, let's move on. This is great. Let's move on to age because we're almost out of time. So how does age affect someone's health? This is pretty also obvious, but.
I think sometimes with the elder population, they're taught not to challenge this person who's perceived as an expert, which ultimately may be detrimental if they're not willing to challenge the doctor's assessment.
Okay, yeah, absolutely. So this is sort of an older view of medicine. The doctor is the one who tells you, and then you kind of just follow or don't ask questions. Yep, that's great.
Another one is.
Sorry, we're back on you.
Sometimes if they have hearing issues or their hearing aids aren't working properly, they just nod at what the doctor's saying and think they're understanding, but they're only picking up every fourth or fifth word, you know?
Yes.
So that can greatly affect sort of their knowledge and what they're supposed to be doing.
Absolutely.
Their frailty sometimes affects their ability to even get out to an appointment.
Yep.
Sometimes they don't want to be treated. They're older, they've had a full life, and they're ready to just be comfortable. The doctor's instinct is to cure and to heal.
Hey everybody, time to wrap up. You ready? So we're gonna keep moving. We're gonna stay in our groups. Although with my group, I'm gonna make you guys come down in here because I know those people in the back can't hear me. And here's what we're gonna do. In your packet, you have a case study. It's called Mr. Smith. So you're gonna take that out, and then each of the facilitators is gonna read that to you, and then we're gonna have a discussion about what things you'd be concerned about as a care manager and how you might address them. Okay?
So we'll get to, we got to almost everything, so. All right, does everyone have their case study? I have to take off my glasses to read. All right, I'm gonna, you know what, I'm gonna ask you, what do you prefer? Do you want to read it on your own? It's a little bit long, or do you like me to? Read it up there. Sorry? Yeah, or what do you want to, sometimes I don't like to be read to, but what works for you? I'll read it on. My group wants to read it on their own. I don't need to leave either. Yeah.
So is the consensus that you guys are going to read this on your own, or do you want me to read it out to you? Who wants me to read it out to you? Raise your hand.
We don't have any packages.
Yeah, okay. So you don't have any packets? That's so sad. Well, we're going to get you a packet.
I think over there.
Okay. Yeah?
Go ahead.
All right, here we go. My best acting exercise. Okay. So, Mr. Smith is a retired 69-year-old man with a 5-year history of type 2 diabetes. Referred by his family physician to the diabetes specialty clinic, Mr. Smith presents with recent weight gain, uncontrolled diabetes, and foot pain. Today, he has a visit with the nurse practitioner. Sylvia, the care manager, is assigned to Mr. Smith to help him arrange any appointments he might need and answer any questions he might have. After seeing the nurse practitioner, Mr. Smith meets with Sylvia. In speaking with Mr. Smith, Sylvia learns that he does not test his blood glucose levels at home and expresses doubt that this procedure would help him improve his diabetes control. What would doing the numbers do for me? He asks. The doctor already knows the sugars are high. Mr. Smith states that he has never been sick a day in my life. While talking with Mr. Smith, Sylvia also learns that Mr. Smith has been having trouble sleeping, has had some recent drinking binges, and, quote, sometimes does not want to get out of bed or talk to anyone. Mr. Smith's daughter recently died of a heroin overdose. Although both his mother and father had type 2 diabetes, Mr. Smith has limited knowledge regarding diabetes self-care management and states that he does not understand why he has diabetes since he never eats sugar. Bless you. In the past, his wife has encouraged him to treat his diabetes with herbal remedies and weight loss supplements, and she frequently scans the internet for the latest diabetes remedies. During the past year, Mr. Smith has gained 22 pounds. He has never seen a dietitian and has not been instructed in self-monitoring of his blood glucose. The nurse practitioner has given him a prescription for a blood glucose meter and test strips, a referral to the diabetes educator, who will show him how to use his blood glucose meter, and a referral to the dietitian. She's asked him to make a follow-up visit with her in 1 month. Mr. Smith also has a diagnosis of high blood pressure. Nurse practitioner started him on medication to control it and asked him to start checking his blood pressure between visits if possible. The nurse practitioner suggested there might be a place in town, such as a senior center or drugstore, where he could check it for free, but Mr. Smith is unsure where he might do this. Is that the end of my thing? Yep. Okay, so what we're going to do in our group is talk about the main issues for Mr. Smith and how, if you got this guy as a patient, you might help coordinate and care for him and manage care for him. Okay?
Take it away. Who's going to start? There's lots of issues. Do you want to just discuss it, or is it helpful if I write up notes so people can see?
I like when you write it.
Okay. Keep me on my toes. Okay. So let's start with the things we're concerned about. I don't really like that.
Looks like, it sounds like he hasn't processed his grief and his experiences and depression.
He hasn't what?
Processed his grief.
You said from this.
His daughter's.
I didn't hear you. You said grief from.
Oh, and it's experiencing some depression.
Okay.
I agree. I agree with you.
Right. So whether or not it's related to his diabetes, we don't know. Right. But
Yeah, what are
probably doesn't
some
know.
more issues?
It sounds like no one's ever really explained to him how what he eats will affect his blood sugar levels.
You said nobody explained to him?
Yeah, because he's never seen a dietitian, so they're telling him what to do, but he doesn't understand why.
Okay. So there's a lot
He's in
of
denial about having
misinformation
Right.
about
Diabetes,
right?
He listens to her.
Potential alcohol abuse, addiction.
His support system needs to be educated as well.
It also appears to me that no one has initiated any motivational interviewing with him to engage him, to really have him look at the pros and the cons of his behaviors and what are the positives and the negatives.
What are we going to do about alcohol?
So, some depression, lots of misinformation or not understanding, right, about diabetes and diet and everything else that goes with diabetes. Potential alcohol abuse, his support system, right, because he has the wife who's looking up.
So his high blood
pictures.
pressure.
Right,
is
he's
an
got
issue.
high blood pressure.
And weight gain, if that's
Okay,
what
yeah,
that's
so
like.
diabetes support group, but just here on the alcohol.
Okay, any other issues?
Yeah, a lot of, this guy came in for one appointment and all of a sudden was referred to a lot of people and to fix everything all at once.
Right.
Nobody really asked him what his major problem, what he wanted to address that day.
Okay, so these are, all right, we've sort of identified all the issues, but then getting to what you were saying,
Basic assessment, which
he
I'm
might not
assuming
be
everyone
ready
is doing an
to
assessment.
address all of these. No one's asked
everyone
him.
doing an assessment?
So as in your role as care coordinators,
Does anyone not
what,
do an assessment?
how would you tackle this?
Are you all doing the same? So you all have your own design?
They're sort of tagging on to that whole MI piece about what are his
But I just
goals
want
or
to hear from
goal.
other people.
Why did he
So we'll have
present,
a
what are
thing
his
to
biggest
you.
concerns?
And
Because
perspective
there
was
are obviously a lot of medical
alcohol.
goals, but what are his
What
goals?
would you do?
So that would be a starting point for him to
Resources.
want
You do.
To find
Anybody else does.
I would have to give them
his goals.
Yeah, okay.
refer them to the Council on Aging, the Substance Abuse Council.
I love that you guys said that.
Okay.
And that would include help him be, self-reflect in what the barriers are and and how he can be supported to understand his situation better. So make it person-centered for him.
Do other people have that? Recovery coaches? Is this a new idea?
How to address.
That's what I'm saying. I'm like trying to get some sharing of ideas here.
So great, so find out his goals, what are the barriers to his goals, and then how to kind of break through those barriers.
If you see the dietitian, he's got the diabetes, but he's also got the weight gain and the hypertension needs. So that dietitian needs to know his history so that that one visit or maybe a follow-up visit, they can address everything and not make it seem like we're treating different parts of.
So would it be communicating, right, to dietitians?
Communicating, right, and incorporating him as a person as opposed to he's got this, he's got that. Treating. Care plan.
I would ask him to include his wife, to bring his wife into the picture too.
Hudson County, and the Turning Point centers are now in every county as well.
I think the MI piece to understand how his emotional state is impacting his desire to care for himself.
It's for anyone. So the Turning Point Center is really for
His ability.
resources. Like I said, every county has it. It's kind of a drop-in, and they can, people there can direct them whether they want to be linked to meetings.
Yeah, because what else has happened to him? That's really big.
Daughter.
I would also do an assessment of what the strengths are in his life, like what he finds, sees as supportive. Who, what.
And it's free.
That's great, I love that.
Yeah.
Along with the education, they talked about his foot pain. There are some potentials there, and I just don't know that he even, so it just seems like education regarding some of that.
All right, so this is a lot of stuff. So this is sort of like more of like a method, right? That we're treating the whole person, not so much as like an exact step. Same with this, right? Including his wife as a method. Is this where we would start?
Can I just add something?
Please.
Just kind of in terms of the logistics of follow through. Does he have transportation? Does he need reminder calls? Is there a reliable phone number to reach him at? Things like that.
Right.
Is that a big issue here? People's
Yes.
cell phones, like constantly, like getting used. It's so difficult in New York City.
Absolutely. So find out what's important to the patient.
All right.
And
So
you're going to talk a lot more about that.
What kind of order would we do
This
here?
is key and sort of, for lack of a better way of saying it, like the coolest thing about what you guys
Well, thinking
do
about Maslow's hierarchy, I mean, you have to address the basics first, does he have housing? Is he financially stable?
So
Does he have, those
You
first
are
two
the
things?
people who are really, really going to.
Before you get anywhere else, you have to figure that out.
Okay. The only way to engage a patient is to find out what.
In the building of the relationship, which the MI conversation certainly could, but I almost want to be like, how was that for you coming out of that doctor's appointment? So not even just like, so where do you want to start, but even like the relationship prior to that. Like, how you doing?
I feel like I can get my back better. I can't deal with anything. Then
Kind
you
of
have
do
to
it through
help
this.
them
Right.
Is
I
it?
think you have to address what brought him to the physician. Did he come in because his foot hurts? You have to give him something to help with those kinds of things before you start breaking down all these other things. He comes in because his foot hurts, and he comes out with hypertension and diabetes and a referral to the dietitian and all these things he has to do, and he just came in for something for his foot. So you have to address that one thing, I think, first.
Yeah, it's prioritization, really. Because if you just throw a whole cafeteria of demands at someone, they're just going to shut right down.
They're going to go somewhere else.
Absolutely. I know is it cartilage? You in the back. You were. Oh, sorry. I can't. It looks like a C.
I think you also need to assess what he's done already, where he's been, who he's seen, and probably even a broader history of
what his education level is, like capabilities along the lines of the constraints and the barriers, but maybe just a bigger picture.
Okay. Right. So I don't know if everyone can hear at the back, but really what Betsy was saying is that patients are frequently very, very overloaded.
From these things, are these all things that all of you feel, or are you already doing these, you can do these things easily?
Sometimes the thing that, you know, is most valuable what you're doing is
what are the things that you're not doing as easily?
to help them identify, you know, what they
I think communication with medical professionals is difficult.
Okay.
Neither side is tied to a desk, and there's often phone tags, you know, a lot of phone tag going on, and to find the person to speak to in an appropriate, you know, at the appropriate time.
Yeah.
You know, is difficult.
So we have a whole section at the end on engaging healthcare providers, but yes, we hear that everywhere we go.
And follow up too. I was trying to work on getting a woman orthopedic shoes, and I had contacted the specialist, her diabetic specialist, and you know, I followed up, and they were supposed to complete more documentation that's required for Medicare to cover the shoes, and you know, someone dropped the ball within the office, and that just delayed the woman in getting, you know, what she needed. So sometimes there's just lack of coordination right within the office.
Okay.
I find that in the practices, connecting with a nurse is really great because they can be the caveat to get the information. I think, you know, beyond the reception, to provide that information.
Just sit on somebody's desk. Good.
Anything else?
Okay, we'll take one more.
Empowering the patient too, because a lot of times, even though the doctor's office is blamed for dropping the ball or whatever, I mean, the patient really does need to know if they're wanting something, because that's what it is. They want something. Sometimes they expect that the doctor is going to, so even for anything, okay, well, I thought that call was there, but if that's what your diabetic shoes is about, you need to be able to say, oh, by the way, what about my diabetic shoes? Even if it's after you've left the office, before you've left the office, but after the provider is gone. So I think patients just need to know that they can say something as well.
I think that's really complicated. I was in the field with a case manager, and we were visiting a client who's 87. She has dementia. She's living in her home with her 3 grandkids and her 4 great-grandkids.
Hi, everybody. So I know everyone's doing great work, but we actually are due for a break. We're a little bit over, so we're going to come back in 15 minutes.